heavily as always.
Good evening, madam.
Yeah, good evening.
Very important
Three,
topic, Monica Didi, and
two,
very nice. I
one.
mean, nicely
We are live
selected.
now, sir.
Thank
Good
you.
evening,
Thank you.
everybody. Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Synergy Club 5 webinar on the topic Gynec Oncology Unplugged. Before starting the webinar, we have lamp lighting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
जल्दी ले लो
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is National Executive Member, ISAR. She is Founder President, ISOVAP Chapter of Bhopal. She is National Coordinator, Foxy Infertility Committee, and she is convener of ISAR Perfection Series, Foxy Symbiosis Series, and the present, the Synergy Academic Club Series. Over to Dr. Monica Singh.
Thank you so much, Dr. Vishal. Thank you, Team Intas, for taking our academic activities very nicely forward through the last 2 years. We are nearly at the end of the second year of these academic webinars, and it's always a pleasure to introduce new topics and new brilliant shining stars before, like in the comfort of our home, we can listen to these distinguished speakers. It's a very big, fortune, and we are blessed to have such opportunities showered upon us all the time. So today is the episode 5 of the Synergy Academic Club, and it is my pleasure to introduce the topic for today evening, that is gynec oncology. It's so vast that I think we can go on for 10 webinars without covering the whole of it. But we started to pull out the plug. We started to introduce the topic in front of our viewers so that my team can carry this topic forward. And, with the blessings of our distinguished teachers and mentors, we'll be able to cover every topic, hopefully, by the end of next year. Today, to bless us, we have our chief guest, Dr. Jyoti Bindal ma'am. We have special guest, Dr. B. Aruna Suman, and we have our guests of honor, Dr. Sneha Bihar ma'am and Dr. Rachna Dubey ma'am. Let me introduce the program to you first. Today, the program consists of 3 talks. Each talk has been generously kept as about 25 to 30 minutes so that no speaker is stressed about finishing the talk and they can, take their time. Even an extra 5 minutes is all right for us. So we start with making a colposcopic diagnosis by Dr. Sarita Shamsundar ma'am. And then we have the social relevance of cancer screening and how the screening can be intensified. Why are there are loopholes that sometimes the early lesions are missed, and how can we improve upon our screening programs by none other than the greatest worker in this field, Dr. Poonam Verma Shivkumar ma'am. And lastly, because we all love surgery, we'll have the pelvic anatomy roadmap to laparoscopic radical hysterectomy, where Dr. Ajay Haldar from AIMS Bhopal will take us through all the anatomy of the pelvis and how to deal with these cases in the OR. So I would now like to introduce our chief guest for today, Dr. Jyoti Bindal ma'am, who is, one of the leading gynecologists in MP, a person everybody looks up to. And madam has been in all the cities of MP. She has held very distinguished positions. At present, she is Vice Chancellor of Sri Aurobindo University, Indore. Her major achievements in associations have been the J.G. Jolly Oration Award 21 by National Academy of Medical Sciences, the Foxy Shiromani Award of 2020. Madam has been the president of the Association of Madhya Pradesh OBGY Society, AMPOX, strategic advisor and member of Executive Committee, BTA UK, member COVID Technical Advisory Committee, member of the State PCP Entity Committee, as well as the District Gwalior PCP Entity Committee. She has held distinguished posts like she's been the ex-dean and CEO of MGM Medical College Indore, ex-director Gwalior Mansik Arogshala, ex-Dean and CEO of Government Medical College Shivpuri, and the ex-member of Core Committee, National Human Rights Commission. We are blessed to have you, madam, today amongst us. And it is such a privilege to start this, auspicious day with your blessings. Today, anyway, it's an auspicious day. And we are talking about something which is so close to women's health on the Chhat Puja day. So, madam, we would like to have words of blessings from you.
Thank you so much, Monica. And now at the outset, I'm so thankful to you, Monica, for giving me this opportunity to share a platform with such reverend speakers and co-guests. And I'm impressed. Synergy Club is having its episode 5. And the topics have been very well chosen. So I'm sure the first 4 episodes must have been, again, very bumper. I believe Ajmer and Kota societies are coordinating this. And again, lots of congratulations. And I consider it an honor to share the platform with Dr. Aruna Suman. We all have heard you, Aruna, and it's a pleasure to be here with us. Sneha is, over the time, she's becoming such a good friend, protege, somebody whom I really love speaking to. Gappe marne ke liye, types. She's a good friend. Rachna Dubey is somehow evading me. मैं तो यही बोलूँगी. जहाँ मैं जाती हूँ वो she manages to ask for an excuse. जहाँ वो होती है, I'm somehow not able to read. Rachna, we must meet. Because I always think so high of your achievements and I always hear such good stuff. In fact, day before yesterday, I was mentioning to somebody was getting some obstacle. I said, don't do anything. Just go to Dr. Rachna Dubey, take my name and kaam ho jayega, that kind of thing. So yeah, that's a confidence I've been building. Very, very happy to have such reverend speakers. As Monica already said, I'm sure she'll be introducing them. But more important, I think the gynae oncology has become such a vital subject because we all confront the challenges which are posed on women's health because of late detection. And so early detection, preventive care, and advanced treatment, this really remains the strongest forte which we must work on. And of course, new technologies, surgical innovations, minimal invasive techniques, all these enhance the patient outcomes. And I would say even there is an unprecedented opportunity now to prevent certain cancers, which has never happened before. And this kind of conferences, virtual, physical, they are the right platforms to exchange knowledges, foster collaborations, and set new benchmarks, I would say. And I do hope that all of us here together can bring healing to countless women who are impacted by gynae cancers. And here I would just like to add a small information. In Aurobindo, we made 4 buses, but 2 of them are worthwhile mentioning here. These are what we call mobile units. They're fully air-conditioned, huge buses. The bus for prevention of cancer cervix, which is one of the topics. And Rachna, I would definitely want all of you to come and have a look at these. We have a colposcope. We have a thermal ablation facility. We have biopsy facility in that bus with all the possible labs. And by our app, we send the reports, the frozen section, everything is possible while the bus is in a remote village. So, it's an amazing thing which we are taking it to every village. The second bus is, of course, for breast cancer, ultrasonographic machine, digital mammography, biopsy facility, everything is there in that bus. Of course, the other 2 buses, one is for oral cancer, again equipped with dental chair, and third is for ophthalmology checkup. So these are something, a lot of people are coming with new ideas, but this is something, a very basic thing which we can take to our rural women, because all of us who are practicing gynae would agree that we do get, even today, we are getting patients at very advanced stages of cancer cervix. And the number which we have got of breast cancer is staggering. There's no other word. Out of the 7,000 plus women we've done the mammography through these buses only, I'm talking. We've got something like almost 589 positive cases. Crazy, but we were able to help them. So this is something, all of us need to think about. Once again, thanks a million for having me here. It's a pleasure to be among all of you.
Thank you so much, ma'am. And that it was an eye-opener to hear about the, huge chunk of cases you could get from the 7,000. It almost makes it close to 10%, which is very, very scary. In fact, each one of us would agree that we are entering post-COVID an epidemic of onco. Means, it's just out of the way, but I think we have detected the 10th cancer in my family in the last 10 years. Extended family. So it's there, it's everywhere. It's going to strike you from unexpected quarters. You're going to get badly hit. The family is hit, and it spares no one, whether it's high socioeconomic status or middle class or lower socioeconomic status. Cancer hits everyone, hits very bad. Today, I got one of my very, very distant relatives' PET scan report after CA tongue. That gentleman has got a PET scan positive after 5 months, and the mets are there in the lungs, in the whole of the spine, head of the femur, iliac crest. So it's just now, it's like a hopeless case. So the only hope is screening, screening, and screening. And we are so thankful that Dr. Jyoti Bindal ma'am has told us about these ambulatory services where the patients, if they cannot reach the tertiary center, let the center go to these places. Let us, find out those cases and, detect them.
And we're
Thank-
very open to anybody asking us for those buses in their areas. And the cost to the institution would be minimal because we're just taking the logistic expenses.
Yes, ma'am. Ma'am, very, very true, ma'am. It's a brilliant, brilliant step by the university. And thank you so much, ma'am, for those inputs. And next, I would like to invite our special guest for the evening, a very, very dear senior and mentor to me, Dr. Professor B. Aruna Suman from Hyderabad. Madam is Professor OBG, HOD, Vice Principal, Government Medical College, Jagtial, Telangana, Joint Secretary of FOXI 2021, and the Organizing Secretary of the very, very successful AICOG Hyderabad 2024, which we all enjoyed. Madam has been the National Coordinator of No to Violence Against Women Committee, Practical Obstetric Committee FOXI member, South
Thank
Zone.
you, Dr. Monica. Thank you so much.
Yes, ma'am. And we would like to also, ma'am, give our best wishes to you for all
Thank
your
you.
endeavors and your endeavor in FOXI this year.
Thank you. Thank you so much.
Thank you, ma'am.
Respected Chief Guest, Jyoti Bindal ma'am. And it's really a beautiful experience to share this platform with dear friends. And thank you so much for this opportunity, Dr. Monica Singh. Dr. Sneha Buyar is here. She's a very, very closest friend of mine, down to earth, very hardworking. I feel very happy to be with Poonam Shivkumar madam, who is a very good teacher, and Dr. Sarita also, and Rachana Dubey. Thank you so much for this opportunity. Yes, very well chosen topics, the need of the day. And Jyoti Bindal madam, that's an excellent work you are doing. And yes, we also will plan for something like that. And definitely we'll try to do that, madam, to reach every woman who needs better screening and early diagnosis. Yes, thank you so much. And Monica, thank you so much for this opportunity.
Thank you. Thank you, Aruna ma'am. Thank you for joining and thank you for your blessings.
Thank you.
So I would
All
like
the
to
best.
welcome. Thank you, ma'am. Now I would like to invite and welcome our guests of honor for today evening, Dr. Sneha Bihar ma'am and Dr. Rachana Dubey ma'am. Dr. Sneha Bihar has been always very, very active in FOXI and AMOX, as well as in ICOG, where she has done phenomenal work in all the three, organizations. At present, Madam is holding the prestigious post of Chairperson of Medical Disorder Committee of AMOX 22 to 24. She has been awarded the MS Signature Award for Phenomenal Leadership 2020 Asia GCC Award in 21, and the very prestigious SN Malhotra Individual National Award for outstanding work in rural obstetrics. She does a lot of work in the rural obstetrics, especially with IMA also. She's working in a very big way. She's also the recipient of Dr. Durusha Distinguished Community Service National Individual Award 22, Dr. Anandibai Joshi State Award by Government of Maharashtra, Lokmat Healthcare Excellence Award 2020. With 31 years of experience in the field of OBGYN, there's hardly a conference where Madam is not either giving a keynote or an oration, and she's moderated so many of her panels, and her near-miss obstetric panels, they are really, really, truly eye-openers. And
Thank you, madam.
this goes on. Madam, we would like to hear words of wisdom from you, please.
Thank you so much, Monica. Thank you for that warm and generous introduction, I would say. Indeed, a pleasure sharing the dais with Madam Jyoti Bindal. I know Madam calls me a dear friend. She's really a mentor for me. In fact, Madam Poonam Shivkumar, of course, a very dear friend as well as mentor as well, I would call her, because whatever way she is working in the research and making some policies which are really helpful. It's not I would say it's not only theoretically giving speeches, it's the action with which she's proving her ability. So lots to learn from you, madam. And of course, dear friend Dr. Aruna Suman, special guest, and Dr. Rachana Dubey. I'm sure the revered speakers, Dr. Sarita Shamsundar, who is the authority in her subject. Of course, she's also working very hard for that. And Madam Shivkumar and Dr. Haldar. All three talks are going to be very, very useful. What I feel, Monica, about your programs, the programs are very focused, and going to the depth of the subject through the authority is the best way to learn. And that is how I think it's definitely going to make all the difference what we're expecting. So be the change what you want to see. I think you start from your own self. So thank you so much for making me the part of this. And of course, we always enjoy the knowledge and the activities. Thank you so much.
Thank you, Sneha ma'am, and you will always remain a part of my programs and our team. We count you as one of our, team members. Thank you so much. So, Madam has left us with a very beautiful quotation, be the change that you wish to see. So, there are many changes that have been brought about in Bhopal by Dr. Rachana Dubey. So, let me introduce her, our guest of honor. And she has been the instrument in connecting our private practitioners with the government officials through her very, very meticulous and gentle way of connecting the two. In fact, recently we had a very successful VP conference in Bhopal by Foxy, the West Zone VP Con, in which Madam was instrumental in getting more than 100 government doctors to attend our workshops and learn, all about the skills that they wanted to learn, especially in oncology. Thank you so much, ma'am. Madam is the Director, Health, IEC, and State Nodal for Preventive Gynec, Onco and Infertility, looking a center in charge in the government Kailashnath Kaju Hospital of Bhopal. Madam has several achievements and publications to her credit. She has screened more than 6,000 women for cervical cancer in the last 2 years, and more than 2,000 women have enrolled under the government PCOS center in JB Hospital, Bhopal, and I regularly see prescription in her own hands. Not only PCO, but also these onco patients and also the, adolescents. So she's very passionate about the programs that she's conducting. She has got a very prestigious, she enrolled in the Harvard School of Public Health, Emerging Women Executives in Healthcare and Preventive Gynec program in June 23 and successfully completed it. She is also an avid writer. She has written the Complete Contraceptive Technology published by the National Institute of Health and Family Welfare, and authored a book on organ donation.
Thank you, Monica. Thank you very much. Thank you for this.
The list is, endless, ma'am. But more important is your passion for taking yourself forward. You're always out with something new, with something brilliant, and we enjoy your work so much, and we really respect it, madam.
Thank you. Thank you.
Few words from you, ma'am.
So hello and a very, very good evening to one and all. And Chhat ki bahut bahut shubhkamnaएं. I had just come back from a very big, large program which was organized in Bhopal. Just now, I'm just back from that program. In fact, it's both a very proud privilege and a true delight for me to be here in this program, actually sharing platform with some very inspiring professionals in their field, like Dr. Bindal ma'am, a figure who has actually led with distinction, integrity, and an unwavering dedication towards her work. Dr. Sneha, with whom I've actually shared a lot of platforms and various conferences we have attended together. I'm so happy to be with her. Dr. Aruna Suman, and I would also like to take a special moment to express my appreciation for my very dear friend, Dr. Monica. She is very young, not young, no more young now, energetic, dynamic. She brings so much of vibrant enthusiasm to everything that she undertakes. She has done tireless efforts in organizing these webinars, fostering the collaboration in the synergy episodes which she has been conducting. This is the 5th one. I'm sure she will have many more accolades to her. I feel so fortunate to have her by my side as not only a colleague, but also as a very cherished friend, Monica. And as a director, health and state nodal for preventive gynecology, I very strongly feel that cervical cancer is not only it's not only a medical concern, but also a profound social issue which is impacting women across communities. And I'm so happy that this topic has been taken up in this webinar, and especially in the resource limited settings which we have in the government sector. Despite being a preventable and treatable problem, it still remains a leading cause of cancer-related deaths, as Monica was earlier mentioning in the initial part of the discussion. Early diagnosis is actually pivotal in fighting against cervical cancer. And so we have to encourage a lot of doctors to move forward and come forward to encourage patients also to get the VIA screening, pap smear screening. And it's also essential to detect precancerous lesions in very early stages so that it does not progress to the invasive form. So we have wonderful speakers with us. Dr. Sarita Shyamsundar and Dr. Poonam Verma, Dr. Ajay Haldar. They're going to throw light on these important issues which she has selected, so beautifully selected topics on social issues and laparoscopic surgeries and colposcopic examination of the cases. So thank you for this incredible opportunity, and I'm looking forward to hearing to all of you. Thank you.
Thank you so much, Rachna ma'am. And I hope we collaborate with the government in a positive way to improve the health and life of women in Madhya Pradesh and all over India.
Absolutely.
Thank you, ma'am. And I also, at this point, would like to give thanks and regards to the societies which are collaborating with us. Thanks to their president and secretaries who have joined today's webinar, Ajmer OBGY Society and Kota OBGY Society. Many thanks to these Foxy societies. We always like to coordinate and collaborate, and we go clockwise. We cover the west zone, we cover the north, we go to east, south, and then back again. So it's this whole, this whole academic activity involving all the zones of India, all the Foxy, is brought about by my beautiful program coordinators. I have with me Dr. Neetu Mishra from AIIMS Bhopal, Dr. Purva Bhatkur from GMC Bhopal, and Dr. Nandini Singh Bhati from GMC Bhopal. Dr. Neetu is traveling, so she will not be joining today's webinar, but she is very instrumental in carrying out our academic activities, a very keen researcher, very active, academician. Now, I would like to introduce Dr. Purva. Dr. Purva is assistant professor in the Department of OBGY GMC Bhopal. With, her teaching experience is growing gradually. She is, as we can see, interested in colposcopy. She is a very good orator. I've listened to her this Yuva oration in MPOX, which was, a very super hit talk. She is also a faculty in conferences, written several research articles. We are very proud of you, Purva. Keep growing and keep glowing.
Thank you so much, ma'am.
And next, I would like to introduce Nandini. Though her CV looks small, but she is a very distinguished, academician and OBGY specialist. Again, she is a very, very big boon to my team. Her special interest is high-risk obstetrics, antenatal and gynecological ultrasound, and she also has an interest in reproductive medicine and gynec malignancies. Thank you so much, Nandini and Purva. And now I would hand over the
Wow.
session to you to start the talks.
Thank you so much, ma'am, for your kind words. So, starting our first scientific session, making a colposcopic diagnosis, I invite Chairperson Dr. Monica Singh, ma'am, Dr. Sarita Agrawal, ma'am, and Dr. Suchitra Narayan, ma'am. Dr. Monica Singh, ma'am, is consultant reproductive medicine and endoscopic surgeon, Bhopal Fertility Center.
That's
She is
okay.
also
Purva, that's okay. That's okay. It's okay.
Dr. Sarita Agrawal, ma'am, she will be joining in a bit. Next, we have Dr. Suchitra Narayan, madam. Madam is presently Associate Professor in Rajkiya Mahila Chikitsalaya, JLN Medical College, Ajmer. She also had past experience of working in Lady Hardin Medical College, New Delhi. And she is presently Ajmer's Secretary, OBGY Society, and her special area of interest is in high-risk pregnancy and gynec-oncology. We welcome you, ma'am.
Thank you, ma'am. Thank you.
So I hand over the session to our chairperson to introduce our speaker, Dr. Sarita Shamsundar.
Dr. Suchitra, you can do the honors, please.
A very good evening to all present here, respected. As we all know about this Sarita Shamsundar ma'am, she is very well working in a gynae oncology, and she is presently professor and unit head and heading the unit gynae onco in Suffolk Medical College, New Delhi. Ma'am is a board member of International Federation of Colposcopy and Cervical Pathology, and she received the Asia's first IFCPC World Congress in Colposcopy Cervical Pathology in 2021. Ma'am is an executive member in the Association of Gynecology Oncologists of India, and she is a chairperson of Oncology Committee of AOGD from 2023 to till 2025. So it's my pleasure to introduce you, ma'am, as a speaker, and will be enlightened by your speech. So thank you so much.
Thank you for accepting our invitation, Sarita ma'am. We are so grateful for your time and your
exactly. It will be pleasure
Thank
to
you.
Thank you so much, ma'am. Thank you so
Thank
much.
you so much for the invitation, Dr. Monica and Dr. Jyoti Bindal, Dr. Poonam, all the and all the dignitaries, all the the guests of honor here, and all the chairpersons who are present here. Thank you so much for this invitation. It's actually Bhopal has a special place because I was the coordinator of the the MP. The state government screening program when it started off in 2019, and that was Bhopal was the first city actually where the colposcopy. I was the trainer of the master trainer. So we started with the Clinton Health Access initiatives. So that was when the screening program was started, and I was involved in training the master trainers. And then of course recently the conference which Monica organized, the excellent conference in Bhopal, the West Zone. The Vice President Conference, actually. So we really enjoyed the stay in the beautiful and green Bhopal. So going on to colposcopy, let me just. Can you see my slides?
Yes, ma'am.
I'll just put it on slide. So colposcopy is actually a very simple technique. It's no rocket science actually. It's basically what you have, so simple things that you need to make a diagnosis. You need basically acetic acid, glucose, iodine, some swab sticks. So your basic instrument trolley is just to brush up this is what you need. You need a couple of good speculums, the swab sticks, and freshly prepared acetic acid. So that's what we do. When we make acetic acid every day, we just label it, put a date on it so that we know it is freshly made. Normal saline, And sometimes if photoleading blue is needed for bulboscopy. So you need these instruments for visualizing the endocervix, the endocervical speculum, and then the biopsy forceps, which are different types. The Kervokian it gives a good bite because it gives a square bite, it has sharp, whereas the Bagish is good if the cervix, if there's a growth, then the Bagish will give, you can get tissue, but otherwise if it's only CI and the cervix is tough, you need a titular biopsy forceps. And these are the basic chemicals that you need: freshly prepared acetic acid and Lugol's iodine. And Lugol's iodine is commercially available. It's in the form of this brown bottle. It is to be stored in a brown bottle, and fresh acetic acid has to be made fresh every day. So you get glacial acetic acid, which is available commercially, which just needs to be diluted. 95 ml of distilled water and 5 ml of glacial acetic acid. Also, it's glacial is nothing but it's 100% acetic acid. And it's very important to dispose of your biomedical waste properly. I've seen even big hospitals not disposing of their waste properly. So because that can be really a big biohazard for all of us. So you be environment friendly, and you also make sure all your wastes are disposed in the right containers. So the basic thing is just looking in the colposcope with a low power. First apply saline, and then and you look without the green filter first. Saline is just to remove the mucus and the discharge, and then apply the green filter for the vessel pattern. And that's how the vessel pattern will look like. The normal vessel pattern is nice. You see this branching, whereas if you can see this punctation, something like this is abnormal. And the green seen with the green filter, and also acid fades off. Then you apply acetic acid, which can be with a swab stick. So just apply it and wait for 1 minute. So you can, if you are short of swab sticks, you can just take acetic acid in a syringe and squirt it on the cervix and just wait for 1 minute. And that's how you have to carefully look for the squamocolumnar junction. And that's once you put the timer on after applying acetic acid, so you know that 1 minute is over. And then you can start visualizing the cervix. So that's how you visualize the cervix 1 minute after applying acetic acid. So you should be taking pictures even before applying acetic acid and after, so that you can compare and see where are the abnormal areas. So that's how you take a picture after applying acetic acid. And then you apply Lugol's iodine and then take a picture again. Save your pictures, and that's how if it's iodine negative, that's how it appears. The yellow, you can see this canary yellow color. So when is it indicated? Any screening test which is positive, if it's VIA positive, or a pap smear is abnormal, a pap smear which is ascus and more, has to go for colposcopy. Or HPV, if you're going for HPV testing, any case was HPV positive, especially the 16 and 18 positive, should immediately have a colposcopy. Unhealthy cervix which looks suspicious, cervix which bleeds on touch, a patient who has postcoital bleeding, postmenopausal bleeding, a case of CA cervix also before doing a radical hysterectomy, because you want to see the vagina and make sure there's no extension to the vagina. And as if a patient already has CIN, we want to make sure that there is no vulval, vaginal, and anal intraepithelial neoplasia, because this is any intraepithelial neoplasia. HPV is a multizonal disease. So it's not just the cervix. Usually it is a vagina, vulva, all these areas could be involved. So you want to look for them because the patient can come with dysplasia or problems in these areas. And after treatment of CIN, if the screening test is abnormal, after follow-up of treatment. So what is the basis of colposcopy? So this is the normal cervix that you have. The endocervix has these wavy endocervical epithelium, which is single columnar epithelium, single layered, and the normal ectocervix is multi-layered. The squamous epithelium, and you have these things, squamous cells right till going to the top. And there's a normal this is a columnar epithelium, and that is how the squamocolumnar junction appears, which the junction of the pink and the red epithelium. So that's the squamocolumnar junction, which is normally seen as the junction of the pink and the red epithelium, and that's what you need to look for. So that is the histologically, that is your squamocolumnar junction. So what is the transformation zone? And this identifying the transformation zone is the most important thing of colposcopy. Actually, if you can identify the transformation zone, that's done. Then your job is done. Then you have the job of colposcopy is done. Okay, so that is the most important thing. So the transformation zone from birth to menarche, because there is no estrogen. So normally the squamocolumnar junction is here. So that is a new and the old squamocolumnar junction are at the same place. Whereas from menarche, at the time of menarche, what happens is because of the effect of estrogen. So initially the endocervical epithelium grows out. It comes out onto the ectocervix, and then because the vaginal pH is acidic, so the columnar epithelium gets changed to squamous epithelium, because that is a thicker epithelium and it is more resistant to the onslaught of the intercourse. So it's nature's way of protecting this epithelium. So the columnar epithelium is getting converted to squamous epithelium. And then, so the old squamocolumnar junction is here, and the new squamocolumnar junction shifts a little up towards the os. And the junction between the old and the new squamocolumnar junction is the transformation zone. Now, what happens at menopause is, again, because there is no estrogen, so the squamocolumnar junction shifts inwards, and you're not able to see the squamocolumnar junction. So that's how the transformation zone, that's the junction between the old and the new squamocolumnar junction, is your transformation zone. And what you need to identify when you are doing colposcopy is just identify this new squamocolumnar junction. So that's the most important thing. So the IFCPC, that is the International Federation of Colposcopy, in 2011 described a nomenclature. This is the systematic way of reporting colposcopy findings. When you're doing colposcopy, what are the things you need to see? You need to see the general assessment. Is the colposcopy adequate or inadequate? Is the squamocolumnar junction visible or not? Is it a normal colposcopy finding or is it abnormal? Now, if it's an abnormal, what is the type of acetovite epithelium? Is it thin acetovite? Then it becomes grade 1. If it is dense acetovite, then it is grade 2. Or is it suspicious of invasion? So these are the things you need to look at in colposcopy. So let's see one by one. Now, what do we understand by adequate colposcopy? So adequate colposcopy is when you're able to see everything, the cervix clearly, and there is no blood or mucus obscuring. That is adequate colposcopy. When there is blood or mucus obscuring, then that is inadequate colposcopy. So what is now coming to the type of transformation zone? So if you're able to see the squamocolumnar junction clearly like this, that is a type 1 transformation zone. And if you're not able to see, but you need some manipulation to visualize, so like you can see here, immediately after applying acetic acid, you can't see the squamocolumnar junction. But when you open it up with the endocervical speculum, you can see the squamocolumnar junction. So this is a type 2 transformation zone. So as a type 3 is whatever you do, it is not opening up. So that is a type 3 transformation zone. So here you can see this is without acetic acid. This is with the green filter. Now, after applying acetic acid, you see these dense acetovite areas. And even after putting the endocervical speculum, you can't see the squamocolumnar junction. So that is a type 3 transformation zone. So what are the normal colposcopy findings? So what is the first thing, the commonest is metaplasia. So metaplasia is nothing but going back to your pathology. It's change of one normal epithelium to another normal epithelium. So the columnar epithelium changing to squamous epithelium, which is another normal epithelium. That is what is metaplasia. So how does it happen? Is because there are some reserve cells which are at the base, and then they proliferate, and then the columnar epithelium, which is single layered, is now becoming multi-layered. So that is what is famous metaplasia. So what happens is, originally the squamocolumnar junction was here, and this area was columnar epithelium. So this area now is gradually getting replaced by squamous epithelium. But if there are some areas like this where the columnar epithelium still stays as columnar epithelium, so there's some islands which are left off. So they appear as crypts. So so if you see these crypts, so that means this is nothing but metaplasia. So it's basically change of one epithelium, the columnar epithelium, to squamous epithelium, and this is the area of metaplasia. So this can appear acetovite because of these islands which are left off. And it may cause a problem. I mean, the changes in the sense this metaplasia can cause white discharge later. Now, ectropion is basically the endocervical epithelium. Normally, it is columnar epithelium wavy. If it is, that is the squamocolumnar junction. But if it comes out onto the ectocervix, that is nothing but it's an ectropion or ectropy or erosion that we say. And this is how it appears. It's grape-like. This is the columnar epithelium, which is appearing grape-like. And initially, it does appear acetowhite, but after some time, just be patient and wait, and the acetowhiteness fades off. Now, this can cause a lot of discharge because the columnar epithelium secretes mucus, and that mucus is what the patient has discharge. She complains of discharge, and she can also have postcoital bleeding because this epithelium is very thin. And if there is any trauma, so this can bleed. No, a normal finding is a Nabothian follicle. So it's nothing but it's because of blockage of the crypt openings, and you get mucus retention cyst, and they appear like these buttons here, these white buttons. So this is again a normal finding. Then leukoplakia. What is leukoplakia? It's nothing but it's thickening of this epithelium, and it's because of the warts. So that is what is leukoplakia. So here, even if without applying acetic acid, this area is appearing white. So that is leukoplakia. So it's very important to see, before applying acetic acid, capture the picture, and then after applying acetic acid, see again. Now coming to dysplasia. So dysplasia is nothing but it's change of the reserve cell. Instead of developing into a normal squamous cell, it's becoming an abnormal cell. So the nucleus is becoming big. So that is what is dysplasia. You can see these big nuclei. And here, if it's limited to the lower 1/3, it is CIN1. But if it's spreading, and then the cells also, you get these collocytes, there is perinuclear vacuolation. So that's the typical change in collocytes. And this is high-grade CIN, where you get these big nuclei right up to the top. So the entire epithelium has these dysplastic cells. So that is CIN3. And you may also get mitotic figures here. So the normal epithelium, it is not acetowhite because the light passes through, but in a dysplastic epithelium where there is a lot of nuclear material, the light does not pass through and it gets reflected back. That is because this nuclear material, it coagulates after applying acetic acid, and that is a reversible coagulation. And this, because of coagulation of this nuclear material, the light gets reflected back, and that is what you see as acetowhite epithelium, and that's how it appears. So this is what is a squamous metaplasia, and this is again squamous metaplasia. Here you can see these very light acetowhite areas, which are very diffuse, and also these crypt openings. You can see the crypt openings here. So this is squamous metaplasia. And is this an acetowhite lesion? So if you see here, you see that this appears like an acetowhite lesion. Inside, it is inside the squamocolumnar junction, but then after applying acetic, and this is again with the green filter, but after applying acetic acid, you see that area has gone. So this is nothing but it is mucus. So that is why it's important to see carefully before applying acetic acid and look for acetowhite areas. Usually the acetowhite areas are outside the squamocolumnar junction. Now, this was just mucus and can be very tenacious. You have to be very careful and carefully take it out before going further. Now, any acetowhite lesion, is it CIN? How do we know that? So that is done by scoring. So if you do get a lesion, what you can do is do scoring. So each parameter is actually scored independently on the scale, and the sum gives a prediction for disease. The advantage is it is structured and it is reproducible. So we know of the Reed's index. So this was introduced for the first time in 1984, revised in 1985, where the contour and thickness was replaced by margin. And it was basically to differentiate between subclinical papillomatosis from CIN. And then, so this was the modified Reed score, which had the margins, the color of the lesion, the vessel pattern, and iodine uptake. But there were a lot of gaps in this Reed score because the sensitivity was very low, and the sensitivity for the detection of CIN3 was also very low. So that's when the Reed score was devised, where it was not only all these parameters were taken, but also the lesion size was also taken as an important parameter. And they actually studied all these lesions and correlated with the histopathology, and they found a score of less than 5, excluded high-grade lesions. And the advantage is it is very simple and easy to use for the learners. It has a quick learning curve, and it encourages trainees to consider all the variables systematically. So that's how the SWEET score is. So basically in the SWEET score, you have the 5 different parameters you need to assess when you see a lesion. What is the aceto uptake? And you give a score of 0, 1, or 2. What are the margins? What is the vessel pattern? What is the lesion size? And what is the iodine staining? So let us look at each of them. Now, what is the acetovite? What do we mean by thin acetovite lesion? So this is what is a thin acetovite lesion. You can see this area is pink, but this area is white, but it is not dense white. So it's a thin acetovite lesion. So this gets a score of 1. But if it's a dense acetovite lesion, see here it is a dense acetovite lesion, so that gets a score of 2. Here also you can see that this is a dense acetovite lesion. In fact, it's raised. So here the score is 2. Now the coming to the margins. So if it's a diffuse margin, the score is 0. If it's sharp and irregular margin, score is 1. And sharp and even and with a difference in levels, it is 2. So here you can see that there is an acetovite area here, but the margins are very diffuse. So the score is 0. Here you can see an acetovite area, but the margins are irregular. So that is a score of 1. But if you see this lesion here, and also it appears, you can see very sharp and very dense lesion, and you can almost see that it is appears a little raised. So here you can see that this is a lesion which is raised and the margins are also raised. And if you also get peeling, so this is typical of malignancy, there is peeling of the epithelium. So this is the rag, called the rag sign. And also you can get the scuffed crypt openings. Again, this is an indication of malignancy. Now coming to the vessel pattern. So the vessel pattern, you need to look with it. Is it fine regular? Is it absent or porous or atypical? So this is the normal vessel pattern. You can see nice branching vessels. So this is normal. Again, this is also normal. So you can look for the vessel pattern. You need to look in the acetovite lesion. So you can see these vessel pattern which appears normal. Now you can get fine punctation when there's atrophy, inflammation, metaplasia. But there is no acetovite epithelium. So you need to look at each of these findings and not jump to only one finding. So this is a fine mosaic. You can see this is acetovite area, but there is a fine mosaic pattern. You can see like a mosaic. So this is the score is 0. And here the branching is regular, nice tree-like branching. And in atypical, when the epithelium is atypical, you can see that because it needs a lot of blood supply. So you get a lot of blood vessels start growing in this atypical epithelium. So you get this punctation. So that's how you see punctation on these on colposcopy. And then they also, when it grows further, so these vessels, because now the cells are growing, so they push the vessels apart. So, and there is an increase in the intercapillary distance. So that's what is coarse punctation. So that's how you see as coarse punctation. That's how you see the coarse punctation there. And then once they grow up to the top and then they join amongst themselves. So that's how you get the mosaic. So that's the mosaic pattern there. And that's how you see that on colposcopy. You see an acetovite lesion and you see the mosaic pattern also in the lesion. And then if it's further, if it was going into malignancy, you can see these dilated vessels, corkscrew vessels, all these indicates that it's malignancy. Now, if there are no vessels at all, so this is when don't see any vessels. It is an acetovite lesion, but there are no vessels here. The score is 1. And here you can see this coarse mosaic here, and you see coarse punctation also. So here the score is 2. Here also you can see this coarse punctation. Here again the score is 2. And you also see dilated vessels. This is a case of malignancy, and you can see these dilated vessels nicely. Now coming to the lesion size, what do we understand by lesion size? So when you actually imagine the cervix like a clock and you divide it into 4 quadrants, and you see how many quadrants the lesion is occupying. So you see this lesion this is a acetovite lesion and it's occupying only 1 quadrant. So here the score is 0. Now here you can see it's occupying these 2 quadrants. So the score is 1. And if it's occupying all the 4 quadrants, then the score is 2. And then what is the clock position? Because when you're seeing a lesion, what is the position that it's occupying? It's important to note, because for the next person, it's easy to detect. And also when you want to see next, you want to review them, then you know that this is where it was. Then coming to the iodine staining, what is the iodine staining? Is it, this is what we do, apply Lugol's iodine and look at the iodine negative areas. So normal cervix appears mahogany brown. So that area will be, if it completely takes up iodine, it's 0. But if you get these iodine negative areas, but there is some patchy uptake in between, so then that is the score is 1. But if it's completely yellow, mustard yellow, so the score is 2. So here you can see that this is iodine negative areas, but there are some areas which have taken up iodine, so that is patchy uptake. Whereas here also you can see this patchy uptake, so iodine negative, but there is some patchy uptake. And this is distantly yellow. You can see this is iodine negative, but it is completely yellow. So here the score is 2. Again, so you can see this is the typical canary yellow, and this is the score is 2. Now, you may ask me, why should we do the scoring? Because see, in a modified REACH score, the scoring was if it was between 0 to 2, that means it's likely CIN 1. If it's 3 to 4, between CIN 1 to 2, and 5 to 8, so score of more than 4 indicated CIN 2 or 3. Whereas in a sweet score, it's more defined in the sense that if the score is less than 5, it means it's either a benign or a low-grade CIN lesion. Between 5 to 7, it's high-grade CIN, that is CIN 2 and more. Whereas more than 8 indicates that it is suspicious of malignancy. So it's helpful when you start doing the sweet score and correlating with the biopsy findings. So you know how accurate is your diagnosis. So this is basically a summary of the examination. So examine first after normal saline, then after apply acetic acid 5% and wait for 1 minute, and then apply Lugol's iodine and then visualize. So you do a general assessment for the adequacy, the visibility of the squamocolumnar junction, and the type of transformation zone, and you see if it's a normal colposcopy finding or is it abnormal. And if it is abnormal, what is the grade of the lesion? What is the sweet score? What is your provisional diagnosis? And what is your management plan? Or is it suspicious of invasion? Or is it a miscellaneous finding? So why is it so important to determine the type of transformation zone? Why should we break our heads to know what is the type of transformation zone? Is because so if it's a type 1 or transformation zone where you see that this black area is right outside, or type 2 when it's slightly inside, but you can with manipulation is coming out, you can do an ablation. So that means you can do cryotherapy or thermal ablation to treat this lesion, to destroy this lesion. But if you have a lesion like this, which is going right in, whatever you do, this will not come out, and you'll not be able to, if you do an ablation, it'll take care of this part, but not take care of the part which is inside, the abnormal area that is inside. So you need to go for excision. So you need to take out the whole thing. So that is, so for a type 3 transformation zone, excision is the method of treatment. So that's why it's very important to see what is the type of transformation zone that you're dealing with. So this is you can have a record like this. So this is what we have in our colposcopy clinic with all the details of the patient, the reason for the referral, and the reason, and if she has any medical problems, it's useful to know when you're planning the treatment. What is the indication for colposcopy, the date, what is the colposcopy examination, is it adequate, inadequate, what is the type of TREZ, and is there an acetovyte lesion? If there is an acetovyte lesion, you can just tick the abnormal, whatever the score in this table, and then say, is it normal or abnormal? And if it's abnormal, is it minor grade or major grade? And if you have taken a biopsy, what is the site of biopsy? And then once the report comes, then you can plan the treatment. So basically, colposcopy is a very simple technique. So the IFCPC nomenclature is used to describe colposcopy findings, and any acetovyte lesions are then scored by the sweet score. This is the new dimension. The sweet score is the lesion size, and it's very simple, easy to use, and it has a very short learning curve. So I think this is something, it's something which can be learned very easily. So there's a training program by the Indian Society of Colposcopy also. And so it's, it's something which can be learned at any stage. So because learning should never stop, because life never stops teaching. Thank you so much once again for your patient listening.
Thank you for the beautiful talk, ma'am. We were mesmerized by the
Thank you.
images. I think everybody was glued to the screen to see the images, and it's never like enough. Seeing the colposcopic images is like we keep seeing them, we keep learning new things. And our chairperson, Dr. Sarita Agarwal, has also joined. Madam
Yes.
Sarita, ma'am, would you like to give some concluding
yeah.
remarks, please?
Thank you, Sarita madam. It's for a very, very beautiful lecture and it's very informative. And the pictures are very beautiful. It is just like a painting. The sweat colposcopic score is very beneficial for all juniors and seniors. And thank you so much, madam. Thank you.
Yeah. So the lot of pictures and learning material is available on the WHO IARC, that is the International Agency for Research in Cancer, for the website. So you can log in and see. It's free. I mean, there's no you don't need a password or anything. Anybody can just log in. There are a lot of videos, a lot of pictures, a lot of material for all of us to learn.
Thank you, madam. Thank you.
Thank you.
Very informative, Sarita ma'am. Good
Thank
evening.
you. Thank you.
So I think we can go to session 2 now. Purva, I think Nandini is going to take the second session.
Yes,
Nandini?
ma'am.
Yes, ma'am.
Carrying forward for the second session, I invite Dr. Nandini.
Thank you, ma'am. Good evening to one and all. After having an in-depth knowledge about making a colposcopic diagnosis, we move forward to our next session by a very well-known speaker, Dr. Poonam Verma Shivkumar, madam. Madam is President of Sevagram Vardha of Gynae Society. She will be enlightening us on the topic of determinants for delayed health seeking in women with cancer cervix. To chair the session, I would like to invite our three esteemed chairpersons. First is Dr. Shabana Sultan, madam. Madam is Secretary of Bhopal Obs Gynae Society. Then we have Dr. Priya Gupta, madam, who is the immediate past president of Kota Obs Gynae Society. And next we have Dr. Khushbu Meena, madam, who is the Secretary of Kota Obs Gynae Society. Dr. Shabana Sultan, madam. Madam is presently the head of department of our GMC Bhopal, who caters the maximum number of patients in MP. She has presented many papers in national and national
It's okay, Nandini. That's it.
please. But let me please tell that madam is a master trainer.
You can read one line that is related to Sevagram, because
Yes.
it is related to Poonam madam.
Sure, madam.
Shabana, your CV is very important. We want to listen to it because you have done a lot of work in gynec onco. Yeah.
Yes, ma'am. Yes, ma'am. Madam is a member of esteemed team of PPH Bundle along with Sevagram. She has done various international projects along with Harvard University. She has special interest in gynec oncology and high risk obstetrics, and she is a master trainer of cervical screening programs. We welcome you, ma'am. It's an honor to have you. Our next chairperson is Dr. Priya Gupta, madam. Madam is immediate past president of Kota Obs Gynae Society. She's presently the senior consultant obstetrician and gynec laparoscopic surgeon in Kota Heart Hospital and Shriji Hospital in Kota. She has held various prestigious posts in Kota Obs Gynae Society, and she has been the treasurer, managing committee member, and Vezur coordinator for Family Welfare Committee, FOXY 2022 and 23. We welcome you, ma'am. Our next chairperson is Dr. Khushbu Meena, madam. Madam is Secretary of Kota Obs Gynae Society. She is also the Associate Professor in Government Medical College, Kota. She has done her graduation from the esteemed SMS Medical College, Jaipur, and she's a postgraduate of PGI Chandigarh. She is a master trainer of comprehensive abortion care services and has conducted various labor workshops in FOXY Zonal Conference. Her area of interest are high-risk pregnancy, infertility, gynec endoscopic surgeries. We welcome you, ma'am. I request my chairpersons to kindly introduce the speaker for today, Dr. Poonam, madam.
Yeah, I welcome Dr. Poonam, madam. She is my teacher, my mentor. She is presently working as a director, professor, OB-GYN and medical superintendent Kasturba, MGIMS Sevagram, Varda, and she is related to so many core committees of PPH, related to FIGO, and she also work as a president Sevagram, Varda OB-GYN Society. She is a principal investigator for many international and national projects like
Shabana,
e-patography.
we may start the
Ma'am, but few lines. Lots of awards to her credit. And the best thing is this, that she is promoting e-patography and she has done a lots of work on PPH bundle. And I am one of the candidate who work under her under this for this project of PPH bundle. So it's my privilege, madam, to listen you and to call you on the talk like determinants of delayed health seeking in women with cancer cervix, which is one of the most important factor because patients, they are very reluctant for screening programs. They are not coming regularly when we ask them to come. Even an educated population, we see this behavior. So thank you so
Can
much.
I share my
Accept-
slides?
Yes, ma'am.
Is it visible?
Yes, ma'am.
Yes, ma'am, it's
Okay.
visible.
So a very good evening to all of you, all my dear colleagues, my senior colleagues, and all the students if they have joined. This is something what I'm going to talk to you today is with social relevance. And this is something very practical. So I'm not really going into too much of academics, but I would tell you the real facts which are there and which are responsible that we have not been able to achieve 100% cancer screening. And that is the reason that cancer cervix still remains the first malignancy in genital tract, which is killing the women significantly. So I bring greetings from Mahatma Gandhi Institute of Medical Sciences, an institute which I am extremely proud of being here. We have our mother and child health wing, and we have equally well-developed gynecological department as well. My outline of presentation today would be just a little bit of introduction and then delays in seeking healthcare. We'll specifically talk about what have been the MGIMS experience, what have been the reasons for delay, and then what is the way forward. Now, coming on to cancer cervix, we all know this is a very common malignancy of female genital tract in India. Very life-threatening, especially when the women comes in the later stage. The incidence, if you see in the literature, there are so many incidences given for different countries. And the incidence ranges from 4.8 per lakh women to as high as, I would say, 44.3% when you talk in terms of East Africa. Coming on to the most recent figures which have been given in March 2024, that it remains a fourth common, which was third sometime. So fourth common now cancer in women globally, and around 6,60,000 new cases and around 3,50,000 deaths have been seen in 2022. The highest incidence rate has been observed in Latin America, the Caribbean countries, and also it has been seen that early detection has very clearly stated that if you detect it early, you would reduce the incidence of invasive cancer cervix, certainly. And US has done this where, you know, from 5.6 per lakh women over the years of 30 years, they have reduced it to 2.5 per lakh. The survival rate of cancer cervix have improved over last 40 years, and the reason is certainly the screening measures, which in developing countries are still low. Beauty of the cervix is especially the ectocervix, where the maximum malignancies are seen, that it can be visualized through vagina. So it's easy to detect it much earlier. Yet the problem is that 70% of patients with cancer cervix, they report in advanced stages where surgery is not possible, the survival rates are low, and these delayed presentations are the ones because of which we have not been able to reduce the cancer cervix death. There have been significant delay in seeking medical care by persons with cancer symptoms because they keep on going to different places, and I'll just come on it in a minute. When we say late stages, we are mainly talking about 3 and 4, but some of the literature says that the 2B should also be included in that. And then, of course, as per the SEER histological staging scheme, late stage is defined as the distant stage of cancer presentation at the time of diagnosis by surveillance, epidemiology, and end result. And we all know that when it is later stage or distant stage, many of the organs are involved. Now, when we talk about the hindrances, why cancer survival in cervix is not so good, these are the two major components. One is delay in seeking healthcare, where people are reporting an advanced stage. And second is that they are taking incomplete treatment. They are defaulters, even if they are from the higher socioeconomic status, because of the hazards of the either chemotherapy or radiotherapy. So what is the delay in seeking healthcare? So delay in diagnosis of cancer cervix occurs at various levels, and a different set of potential causes would be operative at each level. Now, broadly, when we say delay, we are talking mainly about patient's delay, but there are several physicians' delay or obstetricians' delay or gynecologist delay as well. And then if you see these both put together, you will see many times there's a lot of intermixing where the patient went to the doctor did not really identify, and then later patient did not go once it was identified. So not only patient delay or the gynecologist delay, but it is also mixed together. And here I have used the word physician because you see the initial part when the women goes to the doctor, they are mainly medical officers, and then, maybe specialized medical officers. It's really very late by the time they report to a gynecologist. And even if they have reported to the gynecologist, the diagnosis has not been made that early. Now, this is something very interesting. Barbier and Davis categorize these delays in accessing healthcare into 5 periods. One is from first biological change to first detectable symptom, then from first symptom to chronic persistent symptom, from chronic persistent symptom to the first visit to the healthcare provider, from first visit to the healthcare provider to the first visit to a cancer specialist, and from the first visit to specialist to first initiation of therapy. Now, when we talk about the delays at various levels, firstly, patient may ignore their symptom and take longer time to approach to a healthcare provider. Second, healthcare providers may fail to diagnose the condition and unsuccessfully treat patients for other competing conditions. And lastly, the delay may occur while the diagnosis of malignancy is being established, and then it is suspected, it is being established, and then finally, the time comes when she is referred to a cancer specialist. A very interesting thing which we noted in our study, and I would categorically say that India has different healthcare providers. Staying in a rural area, I know. In urban area, yes, people go to the doctor, they prefer going to the specialist, and so on and so forth. But the semi-urban areas and rural areas are the ones where they do not really go to the doctor. They go to some or the other kind of traditional healer. some religious priests, some faith healers, some paramedical practitioners, Ayush practitioners, then they go to MBBS doctors and non-gynecological specialists, and finally they go to the gynecologist. So delay is bound to happen. Now, what are the causes of delay in seeking health care in the women with cancer cervix? And if we really categorically look into the patient-related delay, there are several socio-demographic factors like age, early age cancers, which can be treated, although they are virulent, but they don't accept, they don't go in rural areas, they will keep taking treatments from here and there. And when the growth comes that big in the cervix, they report. The elderly age group, you do the camps in the villages, you invite them, they will not come that, because in India, it's a tendency that if I am 60, I am old, and if something happens, it's all right. Socioeconomic status, very important, because it's the lower socioeconomic status which suffers. They have no idea that there are several schemes where, the cancer treatment is completely covered. They have no idea about it. So they are the ones who are the sufferers. A less educated woman and her husband, they do not know anything, so they delay. And then occupational status of the women, most of them are field workers. They do some semi-skilled jobs and so on. So that is also one of the reasons. Here I would like to differ also, because I have seen people from even higher socioeconomic status not tolerating some of the medication in spite of telling them that after a while they'll be fine. They are the defaulters. Now, cancers related factor, such as knowledge about the cancer cervix. And dear colleagues, when I will share with you what have been the situation at our place, you will be surprised that at one point of time, we are talking of the women going to the moon, and we're talking about women doing such good, going to different fields. But there are women who have no knowledge, and the knowledge which is there is so poor that you can't even imagine. Then, of course, personality-related factor where she's submissive, she's denying her symptoms, the family is not allowing her to seek healthcare, and so on. The cultural factors, again, the taboos are there. Access to the care, there is a lot of distance where accessibility of colposcopy or, let's say, simple screening methods are there, which is not available. So these are some causes in delay. We also talk about providers related delay. Now, this is something very important, and I would like to share that we are very close to Andhra Pradesh and Telangana. And to our surprise, are almost 30 to 40% patients, they come from Telangana, Mancherial, Kagajnagar, Belampalli, so on and so forth. And there are certain things which are very, very interesting. And we have approached to the Director of Health Services in Telangana so that, these things should not be repeated and we should not get such cases in late stage. So relation of the patient to healthcare system, because of the distances, because of the cancer hospitals not being close by, then the providers sometimes they do not even recognize the symptom and do not correlate that it could be because of malignancy. They do not even do one gynecological examination before doing hysterectomies, where subtotal hysterectomy comes in, where you have even taken up the uterus and we can't even give radiotherapy. Failure of the providers to provide gynecological examination in first visit and then follow it up. Even when the non-resolution of symptom is there because of the financial gain, they keep on calling the women and do not send them to the cancer specialist. And because of the non-availability of pap smear, the doctors who would see this pap smear, colposcopy, so on and so forth. So diagnostic delay is the main reason. Now, I'll just share with you the study results of MGIMS. MGIMS receives not only patients from Maharashtra, but nearby states. So it comes from MP also, Balaghat area, comes from Andhra Pradesh also, and then several areas of Maharashtra like Chandrapur and all. Now, MGIMS has a very state-of-art oncology unit with exceptional radiation oncology department. Faculty here is par excellent. Tumor board is a regular feature at our place. In India, MGIMS is the only institute and the pioneer to start hyperthermia treatment, which in big, huge cancers, it downstages it. It provides much better results by chemotherapy post hyperthermia. And then late stages, which come from MP, AP, Telangana, Chandrapur, Bhandara, Uttar Pradesh belts, they are much more benefited because they are the ones which come with huge cancers on the cervix. Now, this is our radiotherapy department. If you can see, we are giving hyperthermia therapy. And because I can't take the consent of the women who has cancer cervix being the genital area, so I'm just showing you this therapy of oral cancer, which has been with hyperthermia, and look at the results. And this person has survived more than 6 years now. So coming on to the result, we did a cross-sectional study and qualitative component in it. Our objectives were very simple. One, to identify all cases of cancer cervix for 1 year with their stages in which they reported to the hospital, and then identify the determinants for the reasons why there's delayed seeking health care. All cases of cancer cervix who reported at MGIMS were examined by the doctor. Staging biopsy was done. Diagnosis of cancer cervix was confirmed. And then they were given this pre-formed, pre-tested, modified questionnaire to identify the major determinants. Total 198 cases of cancer cervix came last year. The mean age was 42.3 years. Women who presented in advanced stage had shown two peaks, 30 to 40 years and 51 to 60 years. 78.9% were in advanced stages, 3A, 3B, 4B. Here we did not include 2B. Out of all cases of cancer cervix, 66.3% were educated only till secondary level. 69.3% women lived more than 100 kilometers from even primary healthcare center. 81.2% belonged to lower and lower socioeconomic status. Foul-smelling discharge, vaginal bleeding, and continuous bleeding were commonest complaint in almost 90.3% cases. Time taken by the women to consider her first system serious was nearly 28.4 days, range being 2 to 90 days. After noticing the symptoms, 64% women took all home remedies, local douches, turmeric powder, hot mud application. They had come with burnt vagina because they had put all hot mud inside, and there was some herb application. 66.7% women said that they took advice from old dais who conducted deliveries for self-medications, and the others said that they choose the treatment themselves because they could not come to the hospitals because of lack of transport. On an average, 80.4% women took 9 months to reach appropriate facility for appropriate diagnosis. Now, this is the awareness regarding the disease. So just see, this cancer is a disease where all body organs melt. And if they are melting, then why should I go to the hospital? Disease occurs due to lack of nutrition. There are several nutritional deficiencies, and in these nutritional deficiencies, they were mainly mentioning that if they do not take eggs, animal food, they do not take beetroot, so on and so forth. So they have given us several things which were lack of nutrition in their diet. Disease will show only when boils are all over the body. So they waited that the boil should come and then only they will go to the doctor. This is a disease which eats up the whole family. So cancer to one woman will lead to cancer to the husband, the children, the in-laws, and so on and so forth. And this disease is the one where hands and feet are first involved. So if hands and feet are not involved, it is not cancer. Then the reasons for delay of seeking healthcare. The main reason that they were taking treatment by local people, ojas, Ayush doctors, homeopathic doctors, with the fear that once they go to the hospital, they will be put on a treatment which will take away their hair, which will take away their body strength. There was lack of knowledge about disease, and there was lack of knowledge about that this disease can be treated, and there are several cashless treatment schemes or consequences. Financial constraints were there. That was one major reason. The family did not support them to come to the hospital. That was another reason. Negligent towards health, the careless attitude. They didn't bother to show to the doctor local treatment was good enough. Did not understand the gravity of disease at all. Doctors delay. They were so busy that they had no time to do vaginal examination, and they were treating without vaginal examination. Just look at the percentage, 43.4%. Was most of the time not available. Doctors were not available whenever she went to the doctor. So someone else would see and give the treatment and send them away. Probably they did not know about the disease. So this was the, something very important, that the doctors do not have even the capacity building to identify that this is something, some cervix which is bleeding, postcoital bleeding. They had no awareness about it. Non-availability of provision and diagnostic materials with the doctors, so they could not do the pap smears. Of course, the monetary gain was there, so they kept on continuing with them and never sent the patient to cancer specialist. And there was no specialist doctor available, so there was, for kilometers together, there was no cancer hospital level. Now, what solutions are there for improving health-seeking behavior to detect the cases early or in pre-malignant state? And this is what we have done, and we would certainly promote that mass awareness campaigns have to be done for cancer survey. We have to use media platforms, we have to conduct the camps, identify the village. There is a day where all the pregnant women and all the women come. We can identify that. We have done a lot of innovative ideas where we are showing these kids, we are making the poems in their language and doing these mass awareness programs, almost 100 villages all around MGIMS Sevagram. We're doing diagnostic camps at the villages, PHCs, CHCs, district hospital. VIA is the one which we are using, and we are also using handheld colposcope, which is, made by one of the Dr. Anupma Bhute from Nagpur. Very handy colposcope and gives pretty good results. We have to also ensure that we talk much more about the cashless scheme, and there's awareness about MJPJY, the Rajiv Gandhi Yojana at our place is called Mahatma Jyotibai Phule. So we have to ensure that these schemes, there should be boards, there should be awareness programs, the village head should be informed, and so on. And then, of course, we can sort of give pre-designed, pre-tested questionnaires. We can do some programs, we can do some surveys, and then motivating the village heads through Ashas and ANM so that these women come to the right place. So friends, my advice would be, none of us should feel that, okay, what will we do? They will do who are sitting in the policy decisions or in the tertiary care hospital. No, the doctors from tertiary care hospital, they have to move out of their four walls, ensure that they do system integration and go to the village level and see how they can help. And similarly, the public facilities, private facilities have to cooperate together, show their public-private partnership, and then ensure that we increase the cancer cervix screening and reduce our cancer cervix deaths. From the provider's perspective, and we are doing the training programs. We have done training programs for Government of Maharashtra, where NCD training was done by us with the 3 departments, gynae, ENT, and of course, surgery for the breast cancer. So capacity building of paramedical staff, how do they identify? By doing simple VIA and refer the cases to the right person. follow all universal evidence-based protocols for cancer screening. This is going to improve the coverage. Very simple, cost-effective techniques can be used for identification, and BIA and BILI are the one. Ma'am has very beautifully described that. System integration, as I said, has to be there. The bilateral services has to be there from public to the tertiary care hospital and the lower facilities to the higher facilities. Appropriate referrals should be there. There should be proper referral protocols. Training pre-service and in service on the updates of cancer services screening. And at our place, undergraduates have played such a major role because they are the one to do these skits on several days. They go to the villages because we have adopted villages and they create some awareness. And you see the cancer services screening over the years before was only 23%. We came to 56%. Presently, MGIMS is capturing nearly 68 to 70% cancer screen. And then, of course, we have to, whatever good we do, we have to present and disseminate in CMEs, conferences, policy changes have to be done. And for certainly the government has to take steps to improve the accessibility. These are some interesting, these are the undergraduates who are training. The various posters are put in. We do regular skits and all. So finally, coming to the end of my presentation, and also what should be our take-home message, that if we improve the awareness, certainly it increases the screening percentage and we reduce on our cancer cervix deaths. Early detections are much better. We have to train our paramedical staff and doctors to perform better and help in early detection, precancerous lesion, or at least detected in a stage where it is treatable. The cultural taboos, which are disappearing now because of continuous, educational programs, this is something which we all need to look into. There's a huge scope of motivating village people by motivating these ashas, ANMs, and ensuring that the village heads are motivated. Point of care testing is something very important, and if we can have the people from pathology department who can at least be with us for simple smears, although it will take time for the pap smear to be read, but we are trying this method that we take the pathology people. There's a ambulance in which we keep everything, and where we are very highly suspicious, we can just ask them to see if it is possible by cytology that we should refer these cases to the right place for biopsy. So early stage reporting, diagnosis, management certainly is going to improve the survival. And we trust that we would be able to do 100% screening, but and we'll improve the survival rates for 5 years. But main thing is that there has to be a commitment by all the doctors. There has to be a system integration. There has to be proper referral, and the training of the staff is going to make a difference. With that, these are my references, which I have seen, very recent references. And there's a very interesting BMC Cancer article, which you must see, the health-seeking behavior of the women all over. With that, I thank you very much, and I thank all the organizers for inviting me for this particular very one lecture, which I really, sort of like to present, because this is something which is very, very practical, and we all can assure the government that each one of us, if we take effort, we would be certainly increasing our cancer cervix screening percentage. Thank you very much.
Thank you, madam. It was a real delight to hear from you. You have always been a great admirer to me. I've really been admiring all your sessions, ma'am. And it was an excellent, enlightening, I would say, and in fact, a motivational and inspirational talk to all of us. You have really motivated us all. I'm really moved from the core of heart, and I feel I should also pay all my sincere efforts in enhancing the screening part. Because after your talk about the delays, it is very much evident now. It's a delay on both the fronts. Even the healthcare provider is coming to us on a later stage, and as far as there is a delay on part of the practicing physician or a gynecologist. So we all should make a real sincere efforts, and I think I'm really privileged to chair the session and to hear from you and to listen from you about the in-depth of the problems behind this delayed approach to the patient to us. And I'll definitely correct myself and all the members. I'll definitely promote the same. And I hope we will be really privileged to work collectively in this regard, as you said. Thank you so
Thank
much,
you.
madam. It was really a big, big pleasure to listen from you. Thank you,
Thank
Monica,
you so
ma'am.
much, ma'am.
Thank you.
Just want to share that in the government of Madhya Pradesh is also doing lots of effort, and almost they covered all the district for promoting this cancer screening program, and also they distributed colposcope to various district hospital, to medical college. It's already always available. And ma'am, what we see in our postgraduate time, the advanced cancers are coming. Now there's a little decline. What you say in your 198 patient, how many they came with the advanced stage? You shared
So as I
78.
as I told you, most of the cases, now there are two reasons which we feel that one, maybe the advanced stages have declined, but here being a huge radiotherapy and chemotherapy center, probably we are seeing the patients of later stage coming more here. So there could be a shift in this, that it's not that all the patients are in the advanced stage and they are coming to us. It is simply that all the cases of advanced stages are reporting to MGIMS because
Maybe
very
because of tertiary
cost-effective
care center.
chemoradiotherapy is there.
Yeah.
So that is definitely something which is there.
Yeah.
And
So
screening
efforts
has
are going
certainly
on, ma'am.
improved.
I think all over
Yeah.
India, the effort is going
Screening
on.
has certainly
And
improved. Government is
yeah.
taking a lot of effort. So we are seeing a little less cases of advanced cancers as people are mentioning. But certainly it hasn't reduced the way it should,
Yeah,
the way it has
it should.
reduced in developed countries. So screening has to be made better by our efforts.
Good evening, ma'am. This is Dr.
Thank you,
Julie. I
ma'am.
just have a question, ma'am. And
Yes.
it was a very mesmerizing talk. I just want to know, madam, about hyperthermia. This is something very new which I have heard of. And
Yes.
does it really help so much that it almost.
So I have just shown you one this thing, but I am telling you, our cases which had more than 5 centimeter of growth, they have been treated by hyperthermia. We have actually one of the stalwarts who has come here. He has established radiotherapy department of SGPGI Lucknow as well. So he's the one who's with us, and this hyperthermia treatment significantly reduces the size of the mass. So if she's in a stage 2 or stage 1 where the mass is not so big, we are treating these patients, big masses, treat them with hypothermia. They reduce in size. You restage them, and then you can do Wertham's.
And
So
madam, even
we
lymphatic
are
fits
really
get
doing, and
affected?
this is. And you see, we are the first one all over India where we have started this
No,
hypothermia
this is
therapy.
interesting, ma'am. When I heard of this, I was like, this is
Yeah.
something we have heard of
Yeah.
HIPEC only in ovarian malignancies.
If
That
you
you give
would
high
like, in
temperature.
any of the series, he can give you a presentation of how significantly hypothermia is making a difference. And this is one case which I have shown you because last 6 years this man is coming to us alive and well, very nice. No, आप देखिए तो ज्यादातर लोगों का आप टंग काट देते हैं, ये काट देते हैं, वो काट देते हैं. But you see, this patient is speaking, he is doing very well, he's eating. So
That means quality of
certainly
life
this
also
is a
improved.
new technique, but very interesting technique, which is in
Yeah.
research phase also,
Thank you so much.
plus it is in the implementation phase also.
So, madam,
Thank you so much. Thank you.
this comes under the arena of RT, radiotherapy.
Yes, it is
Okay.
a hyperthermia which helps you in reducing the dose of the radiotherapy also, and effect of chemotherapy on the cells is also very
Madam will
something
show.
very interesting. You all can read into the literature because our third speaker is waiting. So I
Yes,
don't
ma'am.
want to take
Yes,
much
Yeah.
ma'am.
time.
Yes.
Coming
Thank you,
So,
ma'am.
there.
yeah,
I'm
Thank
very
you,
quick.
madam.
thank you very
We
much.
will
Good
like
Thank
to
you so much.
listen from the
Yeah,
consultant what
whenever
you are
you tell
doing.
me, I
Yes.
would invite him.
Yeah,
He's
yeah,
a
sure,
really
ma'am.
a
We will keep
trustworthy,
one
good
webinar
person.
on that.
Yes,
Thank
ma'am.
you, ma'am. Thank you
Thank
so
Thank you
much,
so
ma'am.
much. Thank you so much, everyone.
Thank you.
Thank you so much, ma'am. Now carrying forward to our last session, that is on pelvic anatomy, roadmap to laparoscopic radical hysterectomy. I invite Dr. Ajay Haldar, sir, for the talk, and I invite our chairpersons, Dr. Juhi Agarwal, madam, and Dr. Ritika Mathur, madam. Dr. Randhir, sir, is not joining because of some work. We have Dr. Juhi Agarwal, madam. Madam is
Thank you,
present.
Purva. Leave it. We should move ahead because it's
Let us,
okay.
let us introduce you, Juhi. Just 2 lines. Purva, please
Just
share.
lines. Yes, ma'am. Madam is presently professor and unit head in the Department of Obstetric Gynecology, GMC Bhopal. She is state trainer, CAG and STI. Madam has various publications in national and international journals and is faculty in various conferences, both nationally and in state. We welcome you, ma'am.
Thank you. Thank you.
Next, we have Dr. Ritika Mathur, madam. Madam is presently president, Kota Obstetric Gynae Society. She has special interest in art of vaginal delivery and high risk obstetric. We welcome you, ma'am.
Thank you, ma'am.
Thank you. Now I hand over the session to our chairperson to introduce us, Dr. Ajay Haldar.
Dr. Ajay Haldar sir is the professor in the Department of the Obs and Gynae Society in All India Institute of Medical Sciences, Bhopal, and fellowship. He has had fellowship done in gynecologic oncology. Sir is, I think, sir is a short and sweet person. Chota CV rakha hua hai sir ne.
And
Even I like
very excellent
Yeah.
surgeon. Very good in retroperitoneal anatomy and a
Okay.
very good person also. So
Thank you,
I will
ma'am.
add to
Thank you for the
this.
kind introduction.
See, when the CV is small, the person is extra dynamic.
Thank you so much, ma'am, for the kind words. Okay. Should I share my screen, ma'am?
Yes.
Yes, please.
So my slides are visible? ma'am?
Yeah.
Yes, sir.
Okay. So thanks again for inviting. The retroperitoneal anatomy or anatomy required to understand the procedure of radical hysterectomy would require a very long duration. But in the interest of time, I will keep myself very short on the points which are already used or the anatomical points which are already known when we are doing a normal extrafacial or hysterectomy. And we will talk more about the anatomy which is required beyond the understanding of anatomy used in extrafacial hysterectomy. So it is more about, although I will touch it, but the videos are mainly on the procedures which makes the hysterectomy radical hysterectomy. So apart from the endopelvic fascia, vascular anatomy, and nervous system anatomy, we'll be here talking more on the lymphadenectomy part of the radical hysterectomy than what after the uterine artery is identified and ligated. So from there, the radical hysterectomy starts. So after that, what is required is deep vein, uterine vein identification, then the identification of ureteric tunnel and its dissection, and then if you are going for a nerve sparing or nerve sacrificing hysterectomy, then you also need to understand the nerves part of the pelvic anatomy also. So we'll these 4 points we'll discuss a bit more. And so before we start, just to make our presentation or our procedure more rational, it is imperative on me to talk about the right patient. If we compare the two staging systems, it is the early stage cervical cancer which has been mostly deliberated upon. So first it was only B1 and B2. So now that range has been widened a large number of subgroups to include B1, B2, B3, A1. So these actually this is actually done to emphasize that as the size of the tumor becomes larger, the outcome of the patients become worse and the nodal metastasis is more. So, and the need for radiation becomes, or the outcome of radiations become better if the stage goes up. So although this topic is not on choosing the right treatment, but choosing the right patient for laparoscopy, we have to understand the tumor size and the risks involved. So a tumor size which is less than 2 centimeter is probably most of the people are very comfortable to do a radical hysterectomy. And beyond that, at least with laparoscopy, and beyond that, we generally try to hand over the patient to a radiotherapy friends, and since the outcome is better in that case, except few selected patients where patient may want a primary surgery. The second part of the selection is the selection of the right surgery. So once we have decided that this patient needs, or this patient is the right candidate for surgery, we have to understand what surgery is required. For that, the 2017 Querlo-Moro classification is generally used. For a radical hysterectomy of less than 2 centimeter size tumor, generally a B1 type of hysterectomy would be required with bilateral pelvic node dissection. But if anything is more than that, we have to go for a more radical surgery where we may have to take out at least 2 to 3 centimeter of the vagina. So in that case, our dissection has to be more complete. The understanding of the anatomy becomes even more, challenging there, and the implication of those, understanding into the practice of the surgery is very important, because we have chosen the right patient, but we also have to deliver the right treatment. So we have to decide to what extent of the surgery is required based on the patient. So coming to the anatomy, we all know that as soon as you put a trocar, what is visible is the uterus. But mind you that the uterus should be the last thing to be seen. For a surgeon who is looking for a safe surgery, the best place to look for is the sacral promontory. For that matter, any surgery where the pelvis is not allowing itself to the surgeon to be exposed, the sacral promontory is always available, because it is the highest point on the pelvis, and we can always enter the retroperitoneum. Most of the time we can enter the retroperitoneum through this place. But here in radical hysterectomy, it is rather a necessity, not a choice, because we have to do the pelvic lymphadenectomy, which will start at least from midway between the common iliacs to the obturator area. So entering the retroperitoneum is essential from sacral promontory. And obviously you would want to do a survey before you start the surgery, because any inadvertent or a missed bladder invasion or large nodes on the external iliac group of nodes which are visible will give us the reason not to continue with the surgery, and we have to abandon the surgery. The other approach is to do a lymphadenectomy first, and many people are now doing although it is not into the guidelines, many people are doing sentinel nodes for cervical cancer also, and if they come out to be positive, the surgery is abandoned. So our surgery for radical hysterectomy starts from the sacral promontory. So after the sacral promontory, if you go further down, we all know we have the common iliacs, which divides at their level of sacral promontory into the internal iliac and the external iliac, and we have the ureter also running parallel after crossing from lateral to the medial side. This all gynecologists are aware of. Now from here, there are three systems. One is the external iliac system. You can take the vein and the artery together. Then you have the internal iliac artery, which is the favorite of us gynecologists, whether it's obstetrics, whether it's gynecology, whether it's benign laparoscopy, hysterectomy. We all are nowadays increasingly using the anatomy of the external iliac artery. And then the third thing is the external iliac vein. The external iliac vein is something which we generally don't come across. But once a person or a surgeon is more inclined towards doing radical surgeries, the understanding of the internal iliac vein and its branches becomes very important, which we'll see in subsequent slides. So this is actually in the previous slide, this slide, when we are tracing the external iliac artery, it is, and the vein, what we see is vein is not visible in the beginning of the sacral promontory, but as soon as it reaches the pelvic brim at the end, the vein is it's prominently seen, and we have the medial circumflex vein, which is the caudal extent of the lymphadenectomy, and we also see the inferior epigastric artery. Although
Dr. Haldar,
Yes.
we can't see your slides. It's the first slide is only being displayed. We
Oh.
thought you are directly going to show us videos. That is why I did not object. We
So
couldn't
which
see
slide?
the slide.
Is it
It's
visible?
it's the first slide, and it's not a slide share even. Whether you do it full screen, do it slide share, and please move your slides.
No, I am moving my slides, and my
No,
slides
we
are.
can't see. We can't see. It is only the first slide which we can see.
What you can do is
Now we can see. Now it is moving.
Okay,
Now
so
it is moving.
you can see only the slide.
And do it for full screen. Do it slide. Put it on slide share.
Okay, so it was on slide share and it was full screen, and that time we were not able to see, ma'am.
Yeah. Now we are. I mean, since you moved the slide, I could see it, but still it is not full screen.
Is it moving?
Yeah.
Yeah.
Now it's moving. I thought
it-
you are going to say only
Is it
video.
moving now?
Yeah, it's moving now.
Oh. So now you can see the slide with internal iliac artery, external iliac artery, and ureter.
Yeah, but it should be full screen. Maza nahi aa raha.
Oh, so but then the slide.
Now, yeah, fine, done.
Okay, is it okay now?
Now it is. Yeah, it is okay.
So we were on the external iliac artery with the inferior epigastric artery seen on that. So if we trace further the external iliac artery system, we see the inferior epigastric vein, which is generally not useful or which is not required to be seen for us in normal lymphadenectomy. So now coming to our old friend and our very known internal iliac artery. And we know that internal iliac artery is given off at the sacral promontory, and it divides soon into the posterior division, which goes inside the sacrum, the retroperitoneum, and it's given to the muscles, And what is these, and the visceral branches are what is important for us. And the first branch which branches off on the lateral side, on the medial side, is the uterine artery. We are all aware of this. And if we trace it further, the branch divides it into superior vesical artery and the obliterated hypogastric artery. And generally, when we are doing a benign lymphadenectomy or surgery, up to uterine artery, it's enough. But if you're doing a radical hysterectomy, you have to understand and go beyond the uterine artery and understand the anatomy of the superior vesical artery and obliterated umbilical artery, which is very easily discernible if we dissect the tissue further. So in further dissection of the, we see on the lateral wall, we see the obturator nerve and the obturator vessels. So now coming to the spaces of the avascular spaces of the pelvis. So avascular spaces of the pelvis are actually imaginary spaces in which we create for the convenience of the surgery. And they are basically divided into pararectal and the paravesical
Dr.
space.
Ajay, have you changed your slide? Still now it got stuck again.
Oh, I have been changing my slides.
No, it got stuck again. It is just showing that picture showing sacral promontory, ureter, and external iliac. That is it. Now it is visible.
No, actually, Juhi, it did not change. It was stuck on that slide for a long time. The slideshow is not working. The full screen is also not coming. I think
Now it's showing. This is beautiful slide showing ureter, uterine artery.
is it full
Sorry, ma'am,
screen?
to interrupt in
Yeah,
between. Ma'am,
internal
this is support
iliac.
team.
Yeah,
I will
yes.
request doctor to, unshare his screen and reshare it again and select the screen that he wants to share while sharing it. So this problem won't happen again.
Actually, Juhi, it was not full screen also. It was not slideshow also, at my end, at least. It was on the slide, a normal slide view. All the
Yes,
time.
ma'am, it was
Monica,
not on
I could
SlideShare.
see the slideshow. I
No,
could see the
no,
full
no,
screen and
nobody could see the slideshow.
yeah, I saw.
Then you must have pinched it out or something. It was not a slideshow. We could see
No,
the
actually I enlarged it to see.
That's why.
That is
That's why
visible.
it's not
मैम
fine.
नहीं अभी स्लाइड शो नहीं है
वो slideshow
हाँ,
भी
नहीं है,
था,
नहीं है।
नहीं था. So you
डॉक्टर
can
हल्दर उसको फिक्स करो भाई, क्योंकि वो वही तो सब कुछ क्रक्स है इतना अच्छा।
doesn't matter. We have all the time. Third talk का यही फायदा है. Lot of time. There is nobody waiting except dinner.
So I'll do it again. I have opened the windows and I am selecting the screen which I want to share, which is anatomical roadmap, and I am sharing it again. So my screen is showing the slide as well as the stop sharing option.
All right. And sir, can you please put it on full screen mode? Sir, button right next to the Zoom button. Yes, that one.
Is it full screen now?
No.
No, sir.
I think you go on the top bar. Slideshow written at the top line. No,
Just
no.
beside animation, sir. Slideshow.
Next to animation, there is a word called slideshow written.
Slideshow. Yeah.
Between animation and record.
No, yeah, I'm doing my slideshow here. Doing
Are
my
you having
slideshow.
are you having a good internet there? At
Yeah,
home?
yeah, this.
Okay.
Is it okay now?
No.
Oh, not yet, sir.
Yeah, it's come to the first slide now. Pelvic anatomy. Roadmap.
Okay, so
Yeah, select the slideshow from the top bar, yes. Yes, please. And start from the beginning.
Okay, is it, should I do full screen now?
Sir, from beginning, you just
From
select.
beginning, you have to select the icon from the beginning. Extreme left. Extreme left, yeah.
Yes.
So is it visible now?
No. Please click again,
No,
once
no.
again. Yeah.
I have done exactly the same. So I can see full screen and
Dr. Ajay, what you can do is you can please send your slides on WhatsApp. The support team will pick it up. If you
yeah, it
can.
has videos. I don't know if it'll go or not. They have.
No, WhatsApp, everything goes.
Madam, it will take much time, very much time actually. Videos.
Actually, Dr. Purva told me to send, but it was made since such a last time. So if I do,
Sir, you can send the PPT.
If you send the PPT, we can run it from our end. Even if the videos are not running, it's
Yes,
okay.
sir. You can send the PPT and then you can try running videos from your side only.
it's 1000 MB. It will go and drive. So what I'll do, I'll try to play the videos.
So the file is very big. That's why it is not supporting the sharing.
Okay, so I'll play the videos separately.
You separate the videos in a different, you display them differently and play the slides different in a different screen.
Okay, that I can do.
Dr. Vishal, can you do it, do something from your side?
Madam, I can show the PPT, but videos to transmit the videos on WhatsApp, it will not be possible actually. It will be a lot of time to download and screen share.
So what I have done is I have removed the slides with the videos. So I'll see if this is playing now.
Sir, your videos have sound in it?
No, no.
Please
So is
share the slides. Share the slides again, Dr. Rajat.
Is it moving now?
No, no, you have not shared this.
No.
Not yet. We are not able to see yet.
You have to first start screen share.
Now we can see.
Can you see now?
Yes, sir.
Yeah.
Slides are visible.
Oh, sorry for this.
It's okay. It's okay. It's okay.
Okay, but I don't know if the videos will play. So we are talking about the sacral promontory. Am I visible and visible now? The slides?
Yeah.
Are they moving?
No, it is third slide. Third slide we are seeing.
You are on the third slide and it is not slideshow. It is a small slide.
The slide actually, the screen is okay.
It is not full screen. नहीं हो रहा है तो इसी पे चलने दो आप.
हाँ, नहीं हो रहा है
It's
मेरे.
okay.
It's okay. Yeah.
Is it full screen now?
No, it is not.
No.
But we can enlarge it on our computer.
We'll enlarge and see. Just move the slide. Let's see whether it is moving or
Is it moving?
no.
No, it's not moving.
So you individually click the slide. That is possible.
We have gone to slide
Yes.
2. It has gone to slide number 2. Yeah, you can individually click the slide. Yeah.
Okay, so
Now we can see.
okay, now is it moving now?
Yeah.
So you have to click the slide, then only we are
Yeah,
able
I
to.
understand. There's some big issue with this. So I was on this talking about the avascular spaces of the pelvis. Basically, when we try to do a lymphadenectomy or radical hysterectomy, the primary step is to isolate the blood vessels so that the anatomy is clearly visible and we don't inadvertently injure. At the same time, we follow the anatomical roadways in the retroperitoneum, and we can take them down as per the needs of the surgery, and it becomes easy for us to easy for us to follow the surgical principle. So basically the most important space for us in normal hysterectomy is the pararectal space, where the uterine artery divides the space between the internal iliac artery laterally and the ureter medially, and the uterine artery at the caudal end of it. The space which is covered in this area is known as the pararectal area. And once we medialize the ureter more, lateralize, and then we divide this space further into medial and lateral pararectal area. The lateral pararectal area is known as Ladsko space, and the medial pararectal area is the Okabayashi space. These are the spaces which needs to be developed for a normal vaginal hysterectomy, at least the Ladsko space. But when we are doing a radical hysterectomy, we have to go to the Okabayashi space. Okabayashi space is the medial pararectal area. It is between the rectum and the ureter. That is the place where all the pelvic sphincter nerve and the hypogastric nerve is there in the base of the pelvis. The other area which needs to be developed in radical hysterectomy is the paravesical area. It is the area above the uterine artery and lateral to the bladder, which is marked laterally by the obliterated umbilical artery. So these are the spaces. So here the division is there. So once we have developed, we understand the internal iliac artery, the external iliac artery, the external iliac vein, the median circumference vein on the extent, the caudal extent of the pelvis, and we have developed the paravesical area of the avascular spaces. Then we can proceed towards the pelvic lymphadenectomy. So for this, I will try to share one video which I have selected. Is the video seen?
No.
We can see a still photo, but no, the video is not there.
The slide which you displayed last, all the spaces being specified. That is the thing which you are able to see.
Okay, so I think this video is not playing. So the main part of the presentation were two videos actually, and if the support team says that this cannot be done, then I will proceed with my slides only, because it's already, I think it's late.
Sir, what you want to play the video, right?
Yeah.
I'm playing the video in my browser and not in the slide. Still, it is
So
not.
now you have to change your screen because you have to shift your screen. So I will suggest that you stop share your screen, and once you click on the green button, there will be an option called as share your entire screen at the bottom. Just click on that green button and you will see a pop-up there in the bottom saying share your entire screen.
Yeah.
Click on it and then share your screen. Yes, now switch the browser where it is, where your video is there. Yes, now you can play the video.
Is it visible now?
Yes.
Yeah.
Okay,
Wow,
so
great.
we are talking about the pelvic lymphadenectomy here. And the pelvic lymphadenectomy has to be done in, basically, to make the procedure easy, it is divided into 10 steps. First is the incision of the peritoneum, the psoas muscle and femoral nerve dissection, the lateral dissection. We'll see one of these steps. Ultimately, it is the bearing all the internal, external, and the artery and the venous system of the lymphatic tissue in a systematic manner without avoiding injury. So we'll see the peritoneal incision is done on the exactly on the internal iliac artery by lifting the peritoneum up without injuring. And there are different methods which have been suggested. Here, one of the method is to open it straight on the external iliac artery. The other methods suggested are the posterior U cut, which we run from one of the infundibulopelvic ligament through the pouch of Douglas to the other side, and then we open it. So here we have opened the peritoneum. Now we have started stripping the uh, tissue from the psoas muscle. And the first step is to strip the muscles of the psoas muscle and go to the caudal most extent, where we identify the deep circumflex vein. This deep circumflex vein is the end point of the caudal end point. We don't need to go beyond this caudally. So from there, we start dissecting the tissues from medially from the external iliac vein. Next step is to dive deep into the psoas muscle and the external iliac vein. This is the crevice in which you go inside. First, you encounter the the right external iliac vessel in the form of first artery and then the vein. And then this is a long path which you traverse from the sacral promontory till the end of the pelvis. Bear off, or you take off all the attachments of the lymphatic tissue from the muscle. Mind you, there can be a few vessels which are actually running into the muscle, and once you are opening at that area, there can be bleeding. So you always have to use a bipolar here. So once you have bared all the tissue from the lateral part of this arteriovenous bundle, what we are trying to do is strip off further down to the level of the obturator nerve. So we will go and find the obturator nerve here, which is actually deep to the external iliac vein, and that is the dorsal, or that is the caudal end of the dissection. That is the base of the dissection. We don't go further inside. Then we have the medial dissection. Now we have released all the tissue from the lateral side. Now we are coming on the medial side, so that whatever has been dislodged from the lateral side, we have now started collecting from the medial side. So once you pull the tissue towards side, you will see that there is a gap which has formed. This is because you have released the tissue from the other side. So we develop this gap and we take it further, so that whole bunch of the external iliac node of tissues, the lymph nodes, is collected in en bloc, and this is further taken more caudally And this, if you go, yeah, this is the obturator nerve is now seen, and the external iliac is lateralized. Now going into the paravesical fossa. Paravesical fossa is the extreme end of the pelvis if you go from and dorsal to the ventral part. And this becomes even more important when you are doing lymphadenectomy for a cervical cancer patient, because these are the nodes which are more positive. This is the area where the positive nodes are found more. So this may not be an area where you go in, endometrial cancer, but in cervical cancer, this becomes a very important area. So continuing with the dissection, you are releasing the obturator nerve, and then we have the obliterated umbilical artery which is being released, which is the lateral extent. Now coming to the, we have released it from the lateral, both the lateral and medial sides as well as the end. Now we are coming to the caudal part where we are releasing it. This is the genitofemoral nerve. In this case, the genitofemoral nerve was not seen earlier, but generally what we see once we open the when we look at the pelvic brim, we always see the genitofemoral nerve running on the psoas major muscle. So there can be variations in the anatomy, and one variation we have seen here itself. So we are actually cutting off the end of the lymph chain, and this is the place where you can see an aberrant connection between the external and internal iliac venous system, which is the corona mortis. So now we have to strip the obturator. Although we identified the obturator, we have not stripped the lymph nodes from the obturator. So we will now strip off the obturator node of the tissues, and once the whole of the bunch is ready and collected, we just release it from the cranial end, that is from the bifurcation of the external and internal iliac artery. So, and this area can be little tricky because these are the areas where you always find enlarged nodes, and because of the anatomical location, there can be more chances of bleeding. So this is an after the full clearance. So I'll again go back to the slides. Are the slides visible, ma'am?
Yeah, they are visible. Very nice video, Dr. Haldar.
Okay. So, ma'am, we have seen the lymphadenectomy. So now after completing the lymphadenectomy, now we have to proceed to the radical hysterectomy. So radical hysterectomy, understanding the anatomy is very important. And the most of the anatomy is related to the vesico-uterine ligament, or the misnomer, which is the ureteric tunnel. It is nothing but a condensation of soft tissue which contains lot of venous, then arterial, as well as lot of nerves in it. So understanding this structure is very important. We know the water under the bridge analogy, but beyond that, the anterior part of the tissue which forms the roof of the ureteric tunnel is known as the vesico-uterine ligament. And this vesico-uterine ligament contains several blood vessels, and one most important is the vesico-vaginal, the vesico-uterine artery, which is a branch of superior vesical artery. And similarly, you will see there are a lot of veins which are at the posterior leaf, which is the vesico-vaginal ligament. And these veins are generally many tributaries of the deep uterine vein. The deep uterine vein, as soon as we take down the uterine artery, we lateralize the ureter, we see that there is a multiple veins which are running in the area below that. So that forms the deep uterine vein. So this is a schematic diagram. So this is the arteriovenous structure of the vesico-uterine ligament or the ureteric tunnel. But what makes it more complicated is the presence of nerves. There are two nervous systems. One is the superior vesical, the superior hypogastric plexus, which forms the hypogastric nerves, and later on they are joined by the parasympathetic nervous system, which is the yellow is the superior hypogastric plexus, and then which is joined by the parasympathetic nervous system at S2 and 3 sacral roots, and this form the parasympathetic. So these both join together and they form the inferior hypogastric plexus. The anatomy of inferior hypogastric plexus has been the point of understanding for many researchers for a very long time, because the a radical hysterectomy was seen to have a lot of application on the rectal and bladder functions and vaginal functions later on after the surgery. There was dryness, there was incomplete emptying, there was frequent micturition, defecation, constipation was very commonly seen. So it was understood that understanding the nerve system is very important. So here we can see that there is an X forming here. The posterior part of the X, the lower part of the X are thinner. They are the posterior one is known as the hypogastric nerve, which is the part of the superior hypogastric plexus, and lower is the splanchnic nerves, the lower part of the X. They are joining and forming the inferior hypogastric plexus here. This inferior hypogastric plexus actually divides into a uterine nerve branch and then a bladder nerve branch. So our whole idea is to identify the hypogastric nerve, and identify the splanchnic nerve system, identify the uterine branch, identify the bladder branch, and cut only the uterine branch and save all the other nerve plexus. That is what nerve sparing hysterectomy is all about. So in this slide, we can see that there is separation of the all the veins, which includes the middle vesical vein, inferior vesical vein, and the uterine vein is already cut, and now only the vesical or the vaginal part of the inferior hypogastric plexus is cut. Rest of the plexus is kept intact. So this forms the nerve sparing radical hysterectomy. So to understand the extent of radicality, it is very important to go beyond the understanding of uterine artery, and you have to go deep and understand the deep uterine vein, the superficial uterine vein. There can be multiple deep uterine veins, and these veins are also mixed or further complicated by the vesical veins, and they form the lower part of the ureteric tunnel. The upper part of the ureteric tunnel is formed by an artery, which is generally the part of the superior vesical artery. So we have to take down not only the artery, but if you are doing a much radical hysterectomy, you may have to do the lower, you may have to take down the lower leaf of the ureteric tunnel also, which contains a lot of veins, and most importantly, the inferior hypogastric plexus, which needs to be identified. So this is a cadaveric diagram showing the extent of surgery. The same arteries are shown here. It's type A radical hysterectomy. The second one is type B radical hysterectomy. Type C radical hysterectomies. So now I'll again go to one video, which is actually from the Kyoto Institute of Japan, where Okabayashi originally worked, and the nerve sparing hysterectomy was originally proposed. So is the video visible? Hello?
Yes, it is
Hello?
running. Yes, it is running. It is running.
Now the PPT is running, not the video. Yeah, now
Now
the
it is.
video is running. Yes, yes.
Okay. So we are here. It is a video from the Kyoto Institute, Japan, and it is a type C1 radical hysterectomy, nerve sparing radical hysterectomy. It begins by developing the paravesical space, and lymphadenectomy is done first, which we have covered already. Then So here you can see that the uterine artery is separated, and just below the uterine artery is a superficial uterine vein. But deep to that is deep uterine vein, which needs to be identified. And just below the ureter, you see the hypogastric plexus, which we'll see subsequently. So the uterine artery is ligated and marked for reference, and it is taken down. This is the pararectal and paravesical space we have been talking about. This is just below the uterine artery and the ureter. We see the deep uterine vein, which is very important landmark for doing a radical hysterectomy. So this is the landmark which tells us where are the hypogastric plexus. So just below the deep uterine vein, the splanchnic nerves come and join the inferior hypogastric plexus. And from behind, from the sacrum side, the hypogastric nerve just below the ureter joins this plexus. The lower two parts of the X, what we are talking about, forms the inferior hypogastric plexus. So that has to be identified before a complete nerve sparing hysterectomy can be done without compromising the radicality. So this is the pelvic splanchnic nerve, which is the parasympathetic nerve. And so after lateralizing the ureter, now we can see the other part of the X, which is the hypogastric nerve. Hypogastric nerve is the sympathetic system, which has come from the sacrum, from the superior hypogastric plexus. So both have been identified and marked. So now the posterior pouch is opened so that enough length of the rectum can be achieved, vagina can be taken down. So the hypogastric nerve is being separated and from the ureter, so that when you are taking down the uterosacral ligaments, you don't take the hypogastric nerve. So you are sparing the hypogastric nerve in this case. So now we will open. Now the surgeon is opening the vesicovaginal pouch. So urinary bladder, actually the dissection of the urinary bladder has to be done before the ureteric tunnel can be dissected because of the obvious reasons. And we have to reach to the anterior leaf of the ureteric tunnel. And this is the anterior leaf of the anterior leaf of the vesicouterine ligament. And we can see posteriorly the ureter is entering into it. And this is the place where we have to take down the arteries, and so that there is less bleeding. Use of right coagulation system or right vessel sealing system is very important here, because even a bit of bleeding here will obscure everything, and it is so much deep in the pelvis that the surgeon may lose the sight, and it is difficult to complete the surgery. So the anterior pouch is separated, and the ureter is long, is far away from the cervix now. So this is the paravaginal space which is being developed, and this is actually the posterior ligament of the posterior leaf of the vesicouterine ligament. And this will, if we take this down completely, this will form the ventral parametrium, where the malignancy goes many a times. But we mind you that this is the place where the vesical branch of the inferior hypogastric plexus is also there. So we have to spare the vesical branch. And after separating the vesical branch, we are taking down the paravaginal ligament. So here I've just reversed the video so that we can see the X here again. So after we take down the anterior paravaginal tissue, the posterior leaf of the ligament, so this is the X which is being formed here. This is the inferior hypogastric plexus. First, at the base of the deep uterine vein, we identified the pelvic splanchnic nerves and we preserved them. At the base of the ureter coming posteriorly, we identified the hypogastric nerve, and then we'll be identifying the vesical branch going anteriorly into the bladder and the uterine branch which is going into the uterus, which needs to be divided. So we'll see in the video further. So now the whole idea is to identify, which is actually very difficult, to differentiate between the uterine branch and the vesical branch of the inferior hypogastric plexus. So we have the vaginal vessels which forms the paracolpium. The uterine branch of the inferior hypogastric plexus is the lower one, and this is the whole of the inferior hypogastric plexus. So here the surgeon is taking out only the uterine part of the inferior hypogastric plexus, and he is preserving all the three branches, all the three limbs of the X. So the bladder branch is preserved. The bladder branch is preserved, and the lower branches are also preserved. So in this slide, you can see the bladder branch of the inferior hypogastric plexus is going into the bladder, which is preserved. We have this pelvic splanchnic nerve, which is coming from below, and the cut end of the uterine branch of the inferior hypogastric plexus. So this is the vaginal branch or artery which has to be taken down. And after that, we are ready to do the colpotomy. So now we all are aware of the recent LAC trial in which it was told that the laparoscopic procedures are associated with worse patient outcome. So many of the ardent or many of the enthusiastic laparoscopic surgeon devised methods to stop spillage. So this is one of the methods in which a bulldog clamp is used to clamp the cervix or the vagina just below the cervix so that there is no spillage. Many people use bursting sutures, many people use vaginal tapes, and there is stopped usage of manipulators. So that has led to reduced spillage, and now the colpotomy is done here, and this opens the vagina, and we can see a significant length of the vagina is obtained. And for a C1 type, at least 2 to 3 centimeter of vagina is necessary. A cuff of vagina is necessary to be removed. And so the video ends here. So I think I've taken too much time for the glitches. Just ending with this message that radical hysterectomy is a non-specific term used for a group of procedures of varying extent. So radical hysterectomy is actually not a single procedure. It is actually a group of procedures which has to be carefully chosen for a particular patient. First, the patient has to be chosen whether the person can undergo a surgery, and then if surgery, then whether it's open or a laparoscopic surgery. And if we have decided, then what procedure the patient has to undergo. Careful patient selection and skillful performance of the required procedure is essential for optimal outcome of the surgery in cervical cancer. So I have used open source videos and for the reference. And this end brings to the end, and we are
Thank you
late
so
by
much, Dr. Haldar.
half an hour.
Your video presentations were very good, Dr. Haldar.
No,
I
it's
just have a question. What do you feel is the scope of radical hysterectomy in modern days when we rely more on radiotherapy and since there is a lot of morbidity associated with radical hysterectomy. So what do you say that what is the scope of radical
Yes, ma'am.
hysterectomy in these days?
Ma'am, there is a shrinking population in which we can, very definitely can offer them a radical hysterectomy. It is shrinking because of the newer evidence saying that the radiotherapy works much better and the associated complications of the radical hysterectomy. So that's what my presentation started with, that the patient selection is very important, and there is a the bulk of the disease will decide whether the person can undergo radical hysterectomy or not. And the radiotherapy is considered to be the first choice in any of the
Gold
stages of
standard. Very
It was a wonderful presentation, Dr. Ajay, and really enjoyed it despite the glitches, because glitches happen when there are big videos, so it is okay. So it is always to keep videos at the end of the webinar so that we can extend the talk, and naturally people who are interested will definitely stay on. So from the selected cases that you are operating, what is the 5-year survival rate? Have you found any significant improvement in the past decade or so, or is it remaining almost the same, except that you are now doing radical for bigger tumor sizes, like you mentioned in the beginning?
Now, we are reducing the number of radical hysterectomies for tumors. Earlier, we were going for 4 centimeters. Now, we are not going for radical hysterectomy beyond 2 centimeters, because any stage like 2 to 4 centimeters is B2, and B3 is more than 4 centimeters. So, B3 is shown to have the nodal metastasis is much higher. So, we are restricting ourselves, and thanks to our over enthusiastic radiotherapy friends, they don't let us operate anything above because we have a very active tumor board, so they don't let us operate anything beyond 2 centimeters. So we are safely operating on tumors less than 2 centimeter. Ma'am, operative morbidity is definitely there. The bladder symptoms, the constipation, and the sexual function, which is to be true, is not very much assessed in our setup, is definitely affected. But the kind of patients we cater, it is difficult to follow them for 5 years, ma'am. We don't have a very strong data in doing that, but the immediate follow-ups, what we see for up to 1 year, there is we have hardly seen any major complication in these women when the patient is selected properly. On the other hand, when we see such surgeries of ovarian cancers, the story is different. We see a lot of morbidity, lot of venous thrombosis, lot of pulmonary embolism, which patient come and we see them, encounter them in emergency department, but not that with carefully chosen radical hysterectomy patients.
Great. That's
Thank
nice.
you, Dr. Haldar. It was a very nice presentation because radical hysterectomy is something which requires a lot of skill. Identifying nerve is not at all so easy as you have shown. I mean, being a surgeon myself, I do try, but definitely since you are a very skillful surgeon, it showed in your video also. Thank you so much. Thank you.
Thank you,
And
ma'am.
thank you, Monica Di, for making me part of this webinar. It was pleasure. It was delight to hear all the speakers. Thank you so much.
Always a pleasure to have you, Juhi. Juhi is one of our constant supporters of all my webinars, so she has to be there. And at the conclusion of this Gynec Onco Unplugged webinar, episode 5 with Synergy, I thank all our speakers. We very gracefully went from colposcopic diagnosis to what are the barriers in detecting cancer currently in India, especially in a rural and semi-rural setup. And then Dr. Ajay Haldar took us through various steps of radical hysterectomy and made us revise the pelvic anatomy and all the structures very nicely through excellent videos. I would like to thank our Kota and Ajmer OBGY Society. I would like to thank Team INTA, especially Dr. Vishal Dave and our support team. Tech support has been wonderful today. And of course, my coordinators, my speakers, my chairpersons. Till we meet again, our next webinar scheduled is Synergy 6 on 28th of November. Till then, take care and have a great evening and a great weekend. Thank you so much. Good night.
Good night.
Thank you. Good night.
Good night. Bye.
Good night, everyone.
Support team end the meeting.
Okay.